Hi, everybody. Welcome to the Myasthenia Gravis Association virtual monthly meetup for August. I am Allison Foss, and I am the Executive Director. We are so thrilled that you're joining us this evening. A couple of quick announcements before we get going on tonight's presentation. Following tonight's presentation, you're going to get a survey. And in the survey are announcements of 2 additional virtual monthly meetups in September. We have a bonus one on September 12th at 5 p.m. Central Standard Time, and that will be about CAR T therapy from Cartesian Therapeutics. And then our regular September meeting on September 25th, we will have updates from Janssen and the work that they're doing in the MG space. So a couple of more opportunities for you to join us here in the next month for virtual programming. Additionally, watch your email. If we have any changes, we will send them out. So if you are new to us, we are so glad that you're here. We meet virtually a couple times a month, and then we have in-person groups happening all over in the heartland. So check our calendar at mgakc.org for an event happening in your area. This evening's presentation is going to be kind of informal. If you have questions, Dr. Hayat has said she'll answer them as we go. You can raise your hand or utilize the chat feature. I'll double check to make sure that that's working. But I want to introduce you to Dr. Ghazala Hayat. Dr. Hayat is a neurologist at St. Louis University in St. Louis. She is our clinic partner in St. Louis, and we just love working with her. So we are thrilled to have her speak this evening on antibodies and myasthenia gravis and how to interpret them. Dr. Hayat, I'll let you take it away.
Well, thank you very much, Allison. It's my pleasure and my honor to be part of this. I always enjoy, interacting with patients, the families, and the caregivers. And as Allison mentioned, please feel free to ask a question. If it doesn't get, the chat doesn't get my attention, maybe Allison can see it and then she can ask the question. It's a very brief topic, but I know it's very important to the patients. And what I will do in the beginning, I'm just going to go over what are antibodies, how they are produced, what it means, and how to interpret it. Because now, compared to what we knew about, let's say, 30 years ago, to now we know a lot about antibodies, and still we are learning about. Okay, so this one, I hope you can see my pointer. If not, please let me know. So first, what is an antibodies, or what happens? So you might have heard about another medication we call FC receptor, or which is the Vyvgart. Basically, antigen is something which is foreign to our body, okay? So we have these antibodies, which have what we call variable, or is also called crystalline part of that. And then I'm sorry, antibody presenting, and this is the crystalline part of the antibody. So basically what happens is when the body realizes there is some foreign object, or lots of time, which is the condition with the myasthenia gravis, that our body, for some reason, there are lots of theories, that it starts recognizing its own tissue as foreign and start attacking it. So myasthenia gravis is like that. People who have lupus, it's like that. Some, studies, they say maybe some of the cancer, there might be some theories. There are some theories for like what we call degenerative neurological degenerative disorders, like Lou Gehrig disease or Parkinson's disease. And those are lots of theories that in those which we have not proven. But in myasthenia gravis, that we know about it. And even when I was fellow, it's years and years ago, I always used to tell my patient, I say, this is one of the few neurologic disorders we know what's happening, where it is happening, and how we can help the patients. And then we started learning more and more about it. I will say it's a very exciting time for patients who have myasthenia gravis from their treatment perspective. For years, we just had all older medications we were using, but now many new medications are coming to the market and few are also in the pipeline. So this is basically our variable portion, and this is the constant portion. Okay, so I'm sure you will recognize this, our COVID or SARS, which, they used to call it crown. That's what it was looking like. So this is like a picture I took from the Science News. These are, so when the virus or anything which is foreign to our body, it gets into the system or is in the tissue, our antibodies become very active. So remember I showed you these are the variable and these were the constant, and they are joined by the S, those. So they start going and attaching to that. So anything antigen which is attached to the antibodies is going to just be destroyed. The one which are not, it will be cause, the damage. So that's why when we get vaccination, we're trying to produce antibodies into the system. And then, so that means antibodies are present there and they can attack our system, the foreign bodies, or which we don't want. So I'm just going to spend briefly some time on this neuromuscular junction. So then you understand what happens at the cell level and why these antibodies are important or what they mean, and even if they're negative, what it means. So this is just a schematic. This is our nerve ending, and this is the muscle. So as I said, it's a schematic, but theoretically it looks like almost like this. The nerve fiber towards the end looks like this. And then we have, this is the whole muscle around it. So these are what we call, they have these cleft-like of things. And then we have, these are our acetylcholine receptors, okay? Now, these are what we call quanta or acetylcholine. So most of the myasthenia gravis patients either take or had taken in the past what we call pyridostigmine, or the brand name is Mestinon, which is basically, I'm going to go over what it does here. So I want to, let's say, I'm moving my mouse right now. So in those muscles which hold the mouse and move my finger, all those muscles, what's happening right now, these acetylcholine quanta are released into what we call neuromuscular junction. So it's a simple thing. This is nerve, this is muscle. So this is the junction, but this is not an empty space. This is very important space, which means a lot for the functioning of neuromuscular junction and causing our muscle to contract. So once these are released, you see those green dots, they go and join with the acetylcholine receptors. So these are acetylcholine and they go and join with the receptor. Once they join with the receptor, it causes action potential or send the message to the muscle, and muscle starts contracting. That's a simple thing. Now, we also have what we call safety factor. So we have a safety factor. That means we have all this much more than we needed. So that's why patients who have myasthenia gravis, they might not be symptomatic in the morning because they still are within their safety factors. And most of the studies show it's about 80%. That means you have to drop below that before you will become symptomatic. So if a patient with myasthenia does something repetitively, or they're getting tired, or start in the morning, start working 2-3 p.m., or depending upon very physical activity, they will start getting tired. Once they start getting tired, it's because they passed that safety. And then what happens is, it's not being, the demand is not, so they don't make connection with the acetylcholine receptors, and then muscle don't contract. So if you just keep in mind this neuromuscular junction, which is a schematically normal neuromuscular junction, let's look at the neuromuscular junction in myasthenia gravis. This is not initially, it is actually with disease when it continues that we will develop it. So basically what happens is, these are the acetylcholine receptors. And our system, our immune system, starts treating it or starts thinking that this is a foreign object or antigen. Remember I showed you initially the round thing? What it will do, those antibodies, they will come and attach. Once they attach to these acetylcholine receptors, then those receptors are not available for these green dots or acetylcholine to be able to cause the action potential. And that's why patients will have symptoms that they're getting weaker. Now, the longer this process keeps on going on, you can see it. These kind of clefts are very important because they give us a lot of space, and a lot of receptors can attach to that. And also, so the one thing happens is with time, they're becoming smaller, and eventually it might become just almost a straight line. And also the distance between that becomes much bigger. So when I was talking about pyridostigmine, when we give pyridostigmine, basically what we're trying to do, that this acetylcholine, we're just trying to find, just think about it, that this acetylcholine is trying to find some place that can make attachment and cause the muscle to contract. But then we have a system which we need it as soon as it causes the function or is released, is broken down by an enzyme and they're no longer available. Then we need new quantum. If we take pyridostigmine, which is again anti-acetylcholine esterase enzyme, what will happen is it delays the degradation or breakdown of these acetylcholine. So it gives it a little bit longer time, and if these clefts are much deeper, they can go and attach to at least as many they can and cause the action potential and muscles start contracting. So this is again, it's a very nice, I'm just going to go over that briefly. And then once we talk about MuSK antibodies and also agrin antibodies, we're going to discuss about that. So I just want to bring to the one just before that was really simplistic. So this one is, just look at this, the same exon terminal. It looks a little bit more realistic. It's usually like that. These are the quantas are remain there, but then they are released. So these are those acetylcholine, which I was talking about. Now, these are the acetylcholine receptors, okay? Now, this is the muscle. So what will happen is that we also have, now we know a lot about it, that we have what we call compound called agrin. If you have those antibodies, they will know, or LRP4, which is the most, okay. They attach like this, and then they lead to, this is the MuSK, this like purple thing. So MuSK, LRP4, and agrin. When agrin, which is released, come from there, connects to LRP4, causes MuSK to what we call clustering, or putting them together close, which is a normal function. And so that means when they're released, simply go make connection, and patient will be able to move and do everything. Now you can looking from this perspective, you can see it. If the agrin doesn't come and connect correctly, or LRP4 is not working, which is called low density related protein type, if that's not working, or we have antibodies against that, they will not be able to lead to MuSK stabilization and function, which leads to acetylcholine receptor. So there are pathways which could be affected and lead to myasthenia gravis. So this is the one I was talking to you about before. Acetylcholine, this is acetylcholine esterase, which is going to cause the breakdown of this acetylcholine to acetic acid and choline. But if we give pyridostigmine, this process is stopped, so acetylcholine remains longer in this neuromuscular junction. So these one is just like, you can just basically, for the time, this is our muscle, and these are those clefts I was talking about. So this is the neuromuscular junction. Okay. So what are antibody titers? The antibody titers are the blood test that measures the level of antibodies for specific disorders. There are hundreds and thousands of antibodies we test for different disorders. And then there's some antibodies might be like a little bit abnormal. A lot of patients might be, they call me, oh, I got this, my lupus test or something, ANA, and it is positive 1 to 80 or 1 to 160. And the rest of the numbers in the other tests related to the negative, we just say it's just like, we're just going to watch it. It's nothing to worry about. And so false positive is like you could have antibodies, which doesn't mean that you have that foreign body in your system or your body is reacting to something. It may be another condition or sometimes related to other medications or some other condition. It may come back false positive. More commonly for our, and the other one will be false negative, that the patient does have it, but it's not picking up. So I will go over that when we talk about myasthenia gravis. Now, how do we know that the antibody which you're picking up is causing the disease, right? You do the blood test and you say, okay, patient has acetylcholine receptor antibodies. How do I know that this is related to myasthenia gravis, or it's just like something false positive showing up? So the test which will tell us that these antibodies are really related to this is 2 or 3 things we can. Okay, the first thing is anybody on whom we find those antibodies belong to that disorder. So they might have double vision, they might have droopy eyelid, they might have difficulty speaking, swallowing, or muscle weakness, climbing up step, combing their hair, all of those. So one is that those antibodies present lead to those symptoms. Second is, if you took out those antibodies from patient or somebody and injected into an animal, which is not the model for the disease, that will develop the same disorder. So that means those antibodies go into the system and start attacking, let's say, acetylcholine receptors. And then if that experimental model shows that with injecting myasthenia gravis, specifically acetylcholine receptor antibodies, leads to myasthenia in a model, as I say, that's another one. And the third thing is that you can reproduce it and get the antibodies, and that will, transmitting from one patient to another, that can lead to that. When we have done those things, that will tell us, okay, this antibody titer is pathogenic, okay? So let me just go with that. Okay, so this is basically where your testing of patients who has myasthenia gravis, the testing will go, okay? Or patients, so for a long time, we used to say myasthenia gravis is a clinical diagnosis. Okay, then we started having antibodies, and then later on many more. And then patients are seronegative, or that means their antibody titers are negative. So then we go by our clinical examination. So patient has myasthenia gravis. Then we examine the patient, take the history. Then we test for fatigability of specific muscle groups. So we may ask the patient to look up to see if the eyelids droop, or look at one side, see if they start seeing double. Ask them to count, see if they get short of breath, or their speech changes. Ask them to do some repetitive movement of the arms or legs and see if they get weaker. Once we are done, then we say, okay, it's probable myasthenia gravis, and then we do the antibody testing. The first one is, the most important, is anti-acetylcholine receptor binding antibodies. So binding is the one which I showed you. If you have looked at your blood test, you might see modulating and blocking antibodies. To be honest, if your binding antibodies are positive, that's all we need. If you have just modulating or blocking antibodies and binding are negative, usually we're not sure. That may be a little bit what we call like a epiphenomenon. So I basically just send the binding antibodies, but a lot of labs have a panel. So they just do automatically. If a physician asks for antibodies, they will do binding antibodies, they will do modulating antibody, and they will do blocking antibodies. Now, let's say those are positive, okay? If we had the symptom signs and then this one, so that means patient has myasthenia gravis. If those are negative, so then looking at the different studies, But 80%, just remember, like kind of 80% of the patient will have acetylcholine receptor antibodies. So then we had 20% of the patient who were called seronegative because they had symptoms and they responded to treatment. Those were called seronegative myasthenia gravis. Now we know those other antibodies which I have shown you against MuSK or LRP4, agrin. So let's say the antibody positive, acetylcholine receptor antibody were negative. Then we're going to check for anti-MuSK antibodies and anti-LRP4 antibody. Depends on your doctors. Usually people will send anti-MuSK first. It's much easier, and then you go to specialty lab checking for LRP4 antibodies. Now so what they have found, I just mentioned, we have about 80% of the patients who are acetylcholine receptor antibody positive. So we're left with 20%. Out of those 20% patients, about half of them, depending upon studies, so if they're like out of 100 patients, there are 20 patients who were seronegative, and then you sent from MuSK. So out of those 20 patients, either 10 or 8 might be positive for MuSK. So now you're left with, for every patient who has probable myasthenia or symptoms, you're left with 10 or 12 patients who will have some other antibodies. And then the next antibodies we found was LRP4. How is that? So they were looked into what we call double seronegative. That means patients had no acetylcholine receptor antibodies, and then they had no MuSK antibodies. So they were double seronegative. Now, what will happen is that means we now left of 100%, we left maybe about 10% of the patient. Now you look at the different studies, it varies. Some say out of those 10%, maybe, or out of those 10 or 12 patients, 8 or 9 might be positive for LRP4. Some other studies say maybe 2 to 4 or 5. There's so much variation, so we can't. So we have patients that we do all these 3 tests and still seronegative. Those patients, we do what we call repetitive nerve stimulation tests, and some of patients that are joining today, they might have this a test will show that is positive. If that's negative, then we do single fiber EMG. If that's negative, it's probably not myasthenia gravis. But if one of those antibodies are positive, it's myasthenia. If your repetitive nerve stimulation is positive, that's myasthenia. If single fiber is positive, that's myasthenia. So let me see. I think I see a message in Matt. Okay, good. That's a very good question. The question is in the chat was that I had striated muscle antibodies. I purposefully didn't put it there, but I can discuss that. That's a good point. Striated muscle antibodies by itself won't give us the diagnosis. It is much more useful to tell us if what we call on the extremes of age. So if somebody's 10 years of age or somebody's 70 years of age, diagnosed with myasthenia gravis, like newly diagnosed, high striated antibodies may be related to thymoma, which is a tumor. And nowadays, I mean, most of the people don't check striated antibodies, but there's nothing. But I will not just based on those antibodies going to decide if patient has thymoma or not. I do CT scan. If you're suspecting, you can do MRI scan. So that's what I hope that answers your question. If not, please feel free to put in chat again. So let's talk about acetylcholine receptor antibodies. Okay, so I remember I mentioned where they are. So I just put it also, this question is coming up that over COVID, all those things, are they also working? Because when the COVID started, there were a couple more than that, there were recommendations that the myasthenia patient should not be seen in the hospital, preferably on Zoom meetings, because if they got exposed to COVID, they might have much more prolonged or worse, recovery phase or prognosis. And there is also a question if this one is affecting also that this SARS-CoV or COVID antibodies. We don't have conclusive evidence for that. Now, remember, this is the same way. So you can look at this. This one is a damaged neuromuscular junction. We have fewer antibodies. We have much shallower those clefts. And look at this. I mean, this one is a little bit better. So you have, but still we have the loss of these receptors are going away. So that means we have antibodies attacking those acetylcholine receptor, which this is part of muscle cell and which causes your muscle to contract. So antibodies are attacking this acetylcholine receptor. Okay, so this I got it from LME. I thought was very good. I'm just going to go briefly what is important to check. Okay, so we'd look for acetylcholine receptor antibodies, and it should be just going to remove this. Yeah. If the value is more than 0.4 nanomole per liter in the bloodstream, that's positive, and that's the binding antibodies. Remember, I say I usually don't check blocking or modulating unless and until it's just the package or the whole panel they're doing it. So if it is positive and you had all those other clinical examination, that is consistent with that. It might vary slightly. I will go over that, what it means. If somebody's level is 1.0 nanomole per liter compared to somebody is 23. So this is used in the diagnosis of myasthenia gravis. Remember, I told you the false positives, the rare, some condition can show abnormal antibodies in other neurological condition, which we usually do not even mix up with myasthenia gravis. So your antibodies were positive, is produced by your immune system. Remember, I mentioned that the immune system thinks your acetylcholine receptor are a foreign object. So they think it's an antigen, and they go and attach to that and try to destroy it. In the process, they destroy those receptors. So your acetylcholine quanta or acetylcholine cannot make connection. And then they destroy the neuromuscular junction too. So that's why I always tell patients it's not question of if, it's question of when to start treatment, and that should be as soon as the diagnosis is made, so we don't have long-term permanent deficits for those patients. So antibodies is like antibodies, which I mentioned, are acting against body's own proteins. Okay, so it's mistakenly as a target. Goes to acetylcholine receptors. I went over that. Impedes communication between nerves and skeletal muscle is affected, which I showed you, inhibits and muscle contraction. So that's why patients get tired, and eventually leads to other symptoms like double vision, drooping of your eyelid, difficulty swallowing or chewing, weakness in some specific voluntary muscle. It does not affect what we call involuntary muscle. It does not affect your stomach. It does not affect your bladder. It does not affect your intestine. It doesn't affect your liver or spleen or any of other muscles anywhere. So people say, oh, it's so if you're having swallowing difficulty, I always say it's just like the back of your throat. If you're having way down on your chest, that is not due to myasthenia. That a GI specialist or stomach specialist has to look into that, what's happening. So this is how we make the diagnosis and look for antibodies. Okay. So as I say, most of the laboratories should be 0.05 nanomole per liter. Okay, now if it's higher than that, then it's basically abnormal. Your antibody titer does not always denote the severity. So that's what we're meaning. A patient, him or herself, is the control. So let's say if some patients' antibodies were just like 2.0, he or she might be much worse or severely affected than compared to somebody whose antibody is 10. It happens all the time. But if somebody's antibody titer is 1, and we treat the patient with, let's say, plasma exchange or IVIG or some chemotherapy, and then the patient improves, it's more than likely if you check the antibody titers that go down to 0.0, 0.1, 0.05, something like that. And also another thing is, I put it there, we do not need to repeat antibodies with exacerbations. Because antibody titer does not denote severity across the patients. It's just like for each patient, him or herself. And there are many more objective ways that we can monitor progression or exacerbation. So that's why when you go to a doctor, they ask you a question, okay, if your eyelids droop, how many times during the day it droop, or is it persistent, or is it happens once a week, all those kind of questions, what we call MG-ADL scoring, that will tell us, okay. So practically, I never repeat it. Only time I've repeated it, if patient comes from another outside institution, and they tell me that they had positive antibody titers and I don't have the results, or I just want to make sure if patient is a correct diagnosis, I repeat it. But once I have made the diagnosis, I practically never repeated it. Now I'm going to briefly talk about MuSK antibodies. So this stands for muscle-specific kinase antibodies. So this is the cartoon again. Remember I said, so this is the green is the agrin. MuSK is the blue, this like kind of over oblong. And the LRP4 is called pink or a little bit of that color. Okay. This is the nerve terminal, which I showed it to you. So let's say this is the normal function. Agrin is released, attaches to the LRP4, activates the MuSK, which leads to what we call clustering of your acetylcholine receptor. And then when function comes here, acetylcholine will make connection and the patient will have normal, or not patient, people will have, or human being will have a normal contraction of muscles. Let's say patient had MuSK antibodies. Now you can see that the MuSK, these antibodies have attached to this. Once they attach to that, maybe one may be available, but the other one is not. So this one had to work together. You see that? Now they have been separated. So the process might just stop there. Okay, so MuSK antibodies now it's not letting, and it's not causing clustering, which you can see it here. When you don't have cluster, then those don't work either. And then a patient will get MuSK-related myasthenia gravis. MuSK-related myasthenia gravis is usually a bit more common. Actually, myasthenia is more common in females because it's an immune-related process. But MuSK-related is more common in female and also what we call bulbar, or it's just like around the face. So they might have difficulty speaking, swallowing, eyelids drooping, double vision. They might feel their head is dropping like this. They can't hold it up. And this is a little bit also these antibodies what we talk about is called IgG, IgG4, which usually would not respond to your IVIG. So usually if patients have MuSK antibodies, initially we treat them with plasma exchange, which is cleaning out, taking out the blood, cleaning it or taking it out, all those antibodies. This one, making the blood clear and putting it back into the body. So that is the MuSK-related antibodies. The normal level is less than 1.0 micromole per millimeter. As I said, they have symptoms of myasthenia gravis, which I mentioned that they're usually more face and bulbar type of symptom. And they have absent acetylcholine receptor antibodies. So remember, we had 80% of the patient who had acetylcholine receptor antibodies, then 20% which are left are seronegative. Out of those 20%, out of those, close to 10% will have MuSK antibodies. Okay. Now I put the same cartoon here again because now I'm going to talk about LRP4 antibodies. Okay, so this one is, so remember this pinkish thing is the LRP4. So this is the normal. When agrin is released, it makes connection with the LRP4, which works with the MuSK antibodies, which leads to clustering and normal function. If we have antibodies against LRP4 or agrin, this will stop this process and there will not be any clustering. So, so these are LRP4 antibodies are checked who are what I mentioned before, double seronegative. That means you check the acetylcholine receptor antibodies and MuSK antibodies, and they were both negative. So what we call double seronegative patients. They did a study about 635 patients, and they found in about 19% of the patients. So that means if we have those 10%, there will be only out of, remember I gave you example of 100 patients, 80 patients had acetylcholine receptor antibodies, close to 10 had MuSK antibodies. We're left with still 10 patients. So out of those, if we go by this, about 18, 19, maybe out of those 10 who are left, who are double negative, you might find 2 patients who are LRP4 and agrin-related antibody positive. But you can see different studies are coming, and one study was way up, which I think was not correct. A lot of people ignore that. They say 80%. That means out of the 10 patients left, almost 8 have LRP4, and none of us find that way. So this study said range was 7%, which is like maybe 1 patient, to maybe, 32%. So that means maybe 3 patients out of those 10. So they will have, when you look at your lab result, it will have standard deviation. It should be more than 2.5 standard deviation. They're going to tell you it's positive. Okay, I'm going to stop here and then open up for questions. If you have any question, what those antibodies mean, how do you read about it? One more comment about LRP4. They will have the same kind of symptom, but usually they have found the severity is a little bit milder compared to the other 2 types of myasthenia gravis. Well, thank you for your attention. I'd be happy to answer any questions, or you can put in the chat, or maybe if Alison wants to turn on the microphone.
Dr. Hayat, that was fantastic. I learned a lot. You touched on a lot of great points, so thank you.
Well, you're welcome.
Do we have other questions? I
think they have one question in the chat. Oh, why is prednisone preferred treatment? Okay, the reason is because that's an immune modulator that controls our immune system. So we're trying to tell our system not to attack our own body. So it's the same way if we're putting patient on azathioprine, or which is Imuran, or putting them on Celsep, mycophenolate, all of those medications. We're trying to modulate our immune system. But the problem with that is we need our immune system, right? You have a cold, you need immune system. We have major infection, we need our immune system. Once we give these immune modulating medications, we're lowering the symptoms and treating myasthenia or any immune-mediated disorder, but then we're also putting our patient at the risk of acquiring more infection. So that's why we always have to be very careful that any infection, that's why in COVID, I said there was a myasthenia gravis patient kind of on the top who needed to be taken care of from a neuromuscular perspective, that do this, so they do not get infection because they were at a high risk. Prednisone, I always say, I love prednisone and then I hate prednisone. In the beginning, that is great. The patients are symptomatic. You start on prednisone, it's going to start controlling your immune system. Patient will feel better. But then the long-term side effects are weight gain, high blood pressure, diabetes, thinning of the bone, stomach ulcer, high blood pressure, lots of this. So that's why we start adding, or we used to, we still do it, we add those, what we call immune modulating therapies like azathioprine or mycophenolate. So we hope that they will pick up this immune modulating process, and then we can slowly and gradually decrease the patient's prednisone dose, so cut down on the possibility of risk associated with long-term prednisone therapy. And the newer medications which are in the market, they're trying to work on the actual process and stop it from, like, where the immune system keeps on cascading and cause that. Remember, I showed you the neuromuscular junction, which becomes eventually like the folds are become shallow, and then eventually neuromuscular junction become really flat kind of thing. They stop the process before that. But the same way, they're putting you at a higher risk of having infection. Another medication I mentioned is they looked at the antibodies of what we call the crystalline portion. They're going to go and work on that, and works kind of like getting plasma exchange, but the treatment is working like plasma exchange, trying to decrease your antibodies in the system. So those are, there are lots of newer medication, or at least they're being studied. So let's hope we get faster acting, fewer side effects, and efficacious treatment. That's a very good question. Yeah, is there more damage if the diagnosis is slow and treatment is delayed? For sure. I mean, the thing is, first, I always say, we have to be sure that the patient's diagnosis is correct. Because the treatment is also itself has a side effect, which I just mentioned. So take time, but do not delay it months and months. Just do the test as quickly as possible, which I showed it to you, right? Acetylcholine receptor antibodies, if those are negative, check the other two antibodies. If those are negative, do repetitive nerve stimulation. If that's negative, do single fiber. If that's negative, it's probably not myasthenia. But if because immune system is active, if you have myasthenia, is attacking acetylcholine receptors, or through agrin or through LRP4 antibodies, is attacking the neuromuscular junction. And then eventually it just loses all of its folds, it becomes shallow, and then just like will not recover. If we catch it early, slow down or stop the process, we are ahead of the curve. So that to answer your question is just a kind of, I gave it in detail. Yeah, if the diagnosis is confirmed, delaying treatment can cause permanent damage. How is complement a factor in? Oh, okay. So the thing is, the theories, that's what I was mentioning, the couple of medications which came into the market, the brand name, the Ultomiris. The thing is, when you have antibodies and antigen starts working, if the complements take part, it's called what we call membrane attack complex at the neuromuscular junction. Let me see if I can go back there. Let's see, maybe. Okay, so once the antigen comes here and makes connection with these antibodies, then they will complement will come and then enhances this whole, it leads to membrane attack complex, which will go, and then that's when it causes damage to these folds and everything and makes it shallow. So that's why complement, we have medications which are given to stop the process of complement. We will have what we call complement cascade, starts from C1, 2, 3, 4, 5. It starts at the level of 5AB, and then so it doesn't go further down, doesn't make that attacking complex, doesn't cause the damage to the neuromuscular. Postsynaptic means after the nerve, that membrane. Let me see, there's some other question. Oh, that's a good question. Okay, can you become stable if you had plasma exchange and are on small dose prednisone, also on mastodon symptoms and are just more eyes and blah, blah? Yeah, you can be stable. I'm not saying prednisone, I mentioned I love it, but then I hate it because for long term, you will, prednisone for decades, we have used it, and patients went into a kind of a remission, or at least remission with medication, or what we call minimal manifestation. So if each patient will have his or her own kind of treatment. Remember, that's what I say, your antibodies, your presentation are not the same. So each patient is unique and should be treated as a unique patient. So now symptoms are not just more eyes and bulbar, it depends on patient. I have lots of patients who would not feel comfortable if they're having swallowing difficulty, speaking, or eyelash droopy, or double vision. So I'm a little bit more aggressive treating those symptoms. Now, the next question was, why is myasthenia gravis sometimes associated with malignancy? So it is so it's called kind of, so basically thymoma we're talking about in the thymus gland. Why do we do thymectomy? That will kind of answer your question. So the theory is, or it's like it's shown, there's like embryonic type of cells are on our thymus gland, which kind of cross-react with our acetylcholine receptors. I hope I'm trying to make it very simple. Just think about there is like cross-reactivity from your thymus, and that, so they found it initially just by chance. The patient had thymectomy and that got better, and they did research a long time ago. So that's why even if you don't have tumor, we take it out because we're trying to decrease that cross-reactivity. And studies have shown placebo control that about 2/3 of the patient can go into remission, either with medication or something later on, 2 to 7 years. Now, the same way thymoma and all those, and there's some other, they can lead to, like I think Allison was talking about CAR T therapy and those, they can lead to the kind of your receptor cross-reactivity, everything, which can lead to, or whatever the antibodies they produce or cross-reactivity, cause the acetylcholine receptor antibodies to be damaged. The patient will then develop myasthenia gravis. I hope if it's not clear, please make sure either you can speak up or you can put your question in the chat again.
Those have been great questions.
Well, I'm glad, yeah. Patients are really well informed. That's very nice.
Do we have any other questions? All right. Dr. Hayat, thank you so much for joining us and for your really thorough presentation. We really appreciated it.
Well, it's my pleasure. Thank you very much for having me. Thank you.
Good to see you.
Okay, good to see you too. Okay,
Thank you. Bye, everybody.
Bye-bye.